Hello, I'm here with Dr. Mustapha Bittye. He is the head of the Edward Francis Small Teaching Hospital. That is the preeminent hospital in Banjul, Gambia, and is both the key research, teaching, and clinical referral hospital for the entire country. How are you doing, Dr. Bittaye?
Good morning here from the Gambia. Thank you. We are doing very well. How about yourself, sir?
Okay, great. You're also an OBGYN doctor, and you also have extensive experience with health system management at the Ministry of Health level. So I'm very glad that the Edward Francis Small Teaching Hospital has someone of your experience and expertise at their head. The Society of Critical Care Medicine, along with their implementation partner, IGPC, which is the Institute of Global Perioperative Care, recently completed an oxygen delivery system there at the hospital. And can you give us an idea as to what things were like before that system was installed, and then give us an idea of like how things might have changed now that things have been installed? For example,
thank you very much.
Was a hospital on cylinders, and how were you managing those cylinders on a day-to-day basis?
Thank you very much. And we want to thank CM, Society of Critical Care Medicine, and IPPC, and Johns Hopkins University, and all the partners who supported you to support. It's not very easy to depict and show how it used to be, because we are accustomed to a very new system now that we are enjoying. We tend to forget how bad it was in just the recent past. I tease my colleagues to say now people are asking for a lot every time. They've forgotten how bad it was, because in the just recent past, just looking at our resources, a huge chunk of our resources used to just go to buy oxygen, because minimum we need, to give you an example, the government gives us 1.8 million as our subvention to help run the hospital dialysis every month. And the hospital generally raises around $4 to $5 million dialysis fund. We were using almost about 1 million per week. Almost a lot of the money goes on, because we need 40 cylinders every day. Each cylinder costs about $3,000. From 2005 to a chunk of our funds were going on just oxygen, because oxygen is not something you debate about, you discuss. When there is need for it, you just have to go get it, no matter the cost. And this has given us a big break on the amount of funds, so that we can now buy drugs, we can buy laboratory reagents, and basic things were not available in the hospital because of the cost of it. Second thing is that you may even want it, but it's not available in country. There was no oxygen grade, and what is available is for industrial, but that's what we're using. But because we are the biggest hospital and we need all, so sometimes the plants that we have in country, which are industrial grade type of oxygen, we are not able to meet our needs. So sometimes we resort to going to Senegal and other outside of it. Now you come internally, because if you come internally as well, it's very common if you are walking around the hospital, you see that there are serious cracks, on the floors everywhere. It's because you needed to move the oxygen cylinders everywhere. They fall down. You see the steps are serious with broken, the steps, because people are lazy to bring them down, and there is no ram. So they just throw the empty cylinders down. So they come down the steps like that. And so, because that's easier for them to bring it down. And that spoils all
those cylinders are extremely heavy, I think, also. So I imagine that at times there's probably only one oxygen attendant, because as I understand it was the oxygen attendants that were largely responsible for identifying, by communicating with the nurses, when there was a shortage of oxygen, and bringing that full cylinder of oxygen to the nurse, and then taking the empty cylinder back to be refilled, either by sending it to Senegal, am I correct, or by having it refilled through a contract with Banjul Gas. So I'm sure it took a pretty serious toll on their body, just hauling those cylinders around,
yes,
as well as a toll on the structure of the hospital
and the injuries
and the stairs itself.
And the injuries it can cause. Yeah,
Did
it
you have
causes
some people
what
that might have gotten injured from handling those cylinders
from
also?
their place next to the patients, they can fall. But the attendants, yes, it hurts them. Sometimes it falls on them, and some of them, their backs and other occupational hazard. Like you said, it's true. We only have few attendants at a time, and they're expected to hold the cylinders to near the patient's beds. Some are very heavy, and because of that, they just throw it, and in that way, they spoil the infrastructure and all. And then even the movement is not very fast. Now that we have piped oxygen, you need the oxygen, you just use it within 5 minutes. But the coordination you needed to get the oxygen cylinder to the patient could take hours, because you have few attendants and they're attending to the whole hospital. So, when you need it and it's not there, they have to come, leave where they are doing, bring it up, and before it is connected and all. It used to be a big nightmare. But now things have really improved.
Don't think about how dangerous
now we have our oxygen
the situation is
plants
for patients themselves.
that has been working. Yeah, that is
the risk of those large cylinders falling on a patient. God forbid it should be falling in the pediatric or neonatal area. So I'm happy to see that risk is also decreased. How did the oxygen shortages affect obstetric care specifically? I mean, that's your area of focus. Is there any change in the obstetric area from the oxygen delivery system?
I think the good thing is that it's not only producing the oxygen, but the delivery system also helps in making it available quickly and continuously. You don't have interruptions. So we deliver babies who will need oxygen. The oxygen is already there in the label. Who need oxygen? We don't have to be running. But emergency obstetrics is all about time. You have a fetal distress.
Okay.
You want to start the oxygen. It's already available. You just fix it. It's not about running around. Can you imagine cylinders in between pregnant women or such problems? Then also, in the wards, oxygen is also available there. And here, the government's top priority in healthcare is one, reduction of maternal mortality and child mortality. So they are key and very important. And we have seen a huge impact since the intervention of the IPPC really in the country. It has started going down significantly. One, because of the training, and two, because of the service that is available in the hospital now. The intensive care, the availability of oxygen, the availability of specialists has really improved for service, and it has significantly reduced the maternal mortality. We used to have maternal mortality of 433 per 100,000. Now we are about 289 per 100,000. Our target is to reach 70 per 100,000, but there's a significant reduction already. So for us, and the good thing about this oxygen plant is that, I don't know, but it's the system, how it is brought. Because we've tried another type before, but it hardly works. Maybe for Africa, the system is not put in place. It's never been even handed over, and it has already started having problems, doesn't work. But this one, since we got it, we are so relaxed, it's working, there's preventive, there's a system to check that it's always working, it has some backup, so that if one system doesn't work, another is working. So you hardly ever hear that it has totally stopped. The way it is designed, it's really very good for our type of institution. Any small part has a problem, most likely it's not available in Gambia. So you have to wait for other delivery, so it takes a long time. So the way it is designed to have a backup mechanism where even if there's a problem in one area, another area is still working until you're able to sort the other one out, it's really great ingenuity. And there's a lot of thought process that went into that. I really appreciate that the engineers and all, they look at something that can work in our environment. It was adapted properly for a situation like the Gambia. So that's why since it started, it's been running continuously, and it's the only one running in the whole country in the public sector. So we are really grateful.
So it's the only one running in the public sector, you're saying, or of oxygen plants, or of that technology of oxygen plant?
All oxygen plants in the public sector, this is the only one running at the moment. Wow. And in the last 3 months or so, 4 months.
Is the PSA plant that the Global Fund installed, is that one that's at the hospital, is that one functional right now?
Yeah, that's what I'm saying. I don't know whether it's not suited for Africa or but it has hardly worked. What's the problem? So we are now putting in measures to see how to make it operational. But even though it's been run by UNDP, because it's not yet handed over to the hospital.
Right.
So, we had an international agency handling it, running it, but that would be more efficient than, if it's run by government. But even with that, it hardly works, because
the original plan was that plant was to provide oxygen cylinders that could be sold or given to outside hospitals. So, and then the hospital could possibly get some reimbursement from that. So that's not quite able to happen yet until that plant is functional, correct?
So the plan is that the VSA plan supplied by IGPC, Johns Hopkins, and SCCM is directly linked to the hospital. So it's supposed to
VSA plan.
That's the VSA plan.
Supplied by the SCCM is VSA, right? So we're talking about the VSA plant.
No, I'm saying that the VSA plant is meant to supply the hospital directly through the pipe system. Now,
yes.
the other one, the PSA plant, was to do cylinders, filling cylinders for other sites, other hospitals, so that we can generate some funds and maintain all the plants and all that. Yeah. But unfortunately, it has not worked very well for now. At times when it has worked intermittently, but continuous has been difficult. We are in talks to see how to improve and solve that problem. Yeah, but it's been here for a long time and has not worked. But there's something in this design that allows that there's continuous in the VSA plan that allows it to continuously work. And I suspect it's the double system that they put there.
Huh.
It is done in such a way that a whole unit may not work or may have issue. Another unit will be working whilst you fix that one. Or is it because of the training that was given to the biomedical engineers that we have, but we've not had any issue with it all this time. And it's the only one now working in the public sector. In the private sector, we have some industrial grade type of plants that are working industrial. They are not medical grade, but if we don't have the medical grade, we use.
I see. Huh. Well, our team, the IGPC team, will be happy to talk with you about, doing, possibly a technical evaluation with an engineering group associated with our team to see if we can help get the PSA plant that the UNDP, help to install there, because that could be a great service to the other hospitals that are also needed within the Gambian system. Yeah, so
that would be great.
It's not the plant that we installed. We still are interested in supporting the Gambia health system in general. If there's some way that we can partner or collaborate to do that, I'm sure that we would love to do that.
Thank you.
And we'll also communicate with the Society of Critical Care Medicine to see if they also may have access to some resources to help with that as well.
That would be wonderful. And the other hospitals will really benefit.
So it sounds like one of the first things that you noticed that was different about the VSA plant is that it's able to continuously operate, because all of the other plants were only intermittently operating anyways. And even with that intermittent operation, it was very difficult to maintain their continued functionality. But am I correct that the VSA plant that is piped really is just about continuously functional, except for possibly during power outages?
Yeah, it's actually...
Is that a correct description of that, or can you elaborate on that a little bit?
No, since it came, it's working continuously. And even when there's a problem, the other side will be working. And even if there's power outage, even it's designed in such a way that even if there's power outage, there is already a bank that will be still supplying oxygen until power comes back. So it's not like the power goes up, the oxygen stops. No, it's designed in such a way that you will not believe it, but it's designed in such a way that, even if there is power outage, there's still oxygen going the system until it comes back, then it continues. I think they put some tanks that are they have some tanks that already harbors, or they put some manifolds in other areas where the oxygen cylinders will take over. They did it in such a way that there could be a bridging period until the power comes back.
Okay.
I think it's a very
How
wonderful
has this
design.
changed the
It's
function
a
of the
good
operating
design.
room or the theater?
Yeah. So now the
That's
theater.
great. That's great. How has this changed the functionality of the theater, the operating theater?
So the theater now, I think it gives me just more, but now I don't have to deal with all the challenges they used to have in the theater. Is that before we had some ventilators that cannot work with the oxygen cylinders. Now with this pipe system, they can put it because they need air and both air and oxygen, but the cylinder system cannot do that. So now they have ventilators that work. They have, at the NICU, the ICU. So, it has made life much better for everyone.
So it's
Been on cylinders.
impacted critical care medicine because those ventilators didn't have a way of blending air with the oxygen. I see.
Yes. Before, when you
I
use
see.
oxygen cylinders alone, there are some equipment that we had, we couldn't use them. They were just lying fallow. Now that we have the pipe system, which require both air and oxygen, so they're able to use those type of equipment easily, without having to carry oxygen cylinders, without having to worry about whether it's finishing or not.
Okay, that's fantastic.
So now I have to make sure that it continues.
Oh, go ahead.
They are already used to this now. They are already used to this good system. So as a manager, I have to make sure that this continues. So that's my headache, this high standard. So that's why we are very interested in making sure that it continues to work. And our biomedical, we are always on them to make sure we do maintenance when it's needed. All the patients, they adapt to this new system, which is very good, which improves quality. And the staff are also adjusting to higher quality for patients. So as a manager, I have to ensure that if this is running, it continues to be available.
Right. That's great. Have you seen a reduction in canceled operations? Because as I understand it, if the cylinders were low, then you couldn't start an operation. So is that another way that it's impacted the operating room?
Yes, significantly. And the other thing we used to have, two things used to be. One was oxygen and the other one was anesthetic drugs. Now we are getting both. Direct relief, thanks to your introduction, direct relief team, Jeffrey and the team, isoflurane now is flooded in the hospital. That used to be a big problem. So a combination of the oxygen and anesthetic drugs used to make sure that all these operations were cancelled because, we were not having this oxygen, we were not having anesthetic drugs. But, when we got introduced to direct relief, because they help also in the funding of this program, now we are enrolled into their program as well as a developing country. And I can tell you, within 1 year, the amount of drugs we got, including anesthetic drugs, is millions of dollars worth of drugs. And every
Wow.
The good thing is they did not only stop with EFSPH, our hospital. Now they are supplying about 6 or 7 other hospitals regularly. So they send you a list, you select the drugs you want. No. This project has been wonderful to the hospital.
Yeah, God bless Direct Relief because they were the funder to the Society of Critical Care Medicine for this project, as well as I think as of last year when I was there, they had provided up to around $10 million worth of essential medications.
So that was last year, and since then they've supplied more. They have supplied a lot more.
We're also very thankful for the Jackson State University School of Business team that came to study the supply chain there and documented, the before, and now we have the after of what happened to pharmacy and drugs and medications, which impacts the ability to do anesthesia. Trying to do anesthesia without any inhalational anesthetic is very difficult. Now you have not only inhalational and other anesthetic medications that are necessary for your hospital, but I understand that you're also supplying other hospitals with medications. Is that correct?
Yeah, that's very correct. We are now supplying for the hospital, and I've not heard of running out of anesthetic drugs like isoflurane, sevoflurane for a long time now. Now, we are really flooded with those drugs. Now everybody's happy. You don't have to be so scared and worried. The anxiety is gone. So we really thank God for that. And these drugs are so expensive. They used to take all our funds because we are the ones doing most of the surgeries, and the pharmacies in country, they don't order a lot because of the risk. So the little they order, we go and quickly take it, and then it becomes very expensive because the demand is too high. But now we get these drugs from this directly without any hassle. So we are really grateful.
One of the things that my team and the Society of Critical Care team are most thrilled about in terms of our relationship with the Gambia and working with your hospital administration and the support of First Lady Barrow is that we are very thrilled of how you guys have focused on using your resources and using the money, finances that you save from this, because many, and in fact this does happen in other locations where any cost savings or any revenue that the government people or the hospital people see coming in, they try to reserve that for themselves rather than letting that pass on to the health system and letting that strengthen the health system. But you all are, have your salaries that you're paid for your positions, and you stick with that and allow these resources to help the health system. Can you please elaborate some on how the money that has been saved by not having to import oxygen from not having to purchase oxygen from the industrial oxygen manufacturer, from being able to make the oxygen right there at the hospital and pipe it to the locations, and having all these medications in your supply chain, how have you been able to reallocate those funds to the system or to the hospital? Give me an idea of that.
No, thank you. I think it's not easy because we came around 2 years ago and we found some traditions. Like the CMD has to go with a lot of fuel. You have a lot of privileges. Travel is paid for by the hospital when basic needs are not available. You're spending all the money on oxygen and anesthetic drugs, and you are left with very few. So when patients come, big things are not available. Laboratory is not available. Imaging is not available. So patients basically just see doctors here and then buy everything outside. They go to the pharmacies nearby and up. So what we did was, when we came, we started with ourselves. So as CMD, we said we can only benefit after the basic needs are met. So as CMD, we stop all privileges. I don't receive any fuel or I don't receive any bonus. Since I came, the hospital has never paid for me a to go to any conference or anywhere. I pay myself. And we also said the management has to do the same. It was tough, so they're used to it, but they had to stop, and it was tough. So what we said was, let's make sure the basic needs are available in the hospital. Let patients come and be able to have a laboratory. So we entered an agreement. So the money we are saving, now we are getting reagents for the laboratory. So the laboratory, you go there now, you can do all the basic tests continuously 24 hours. So it helps patients. You come to the pharmacy, drugs are not available. Now we get drugs from Direct Relief. Initially we said, now the rest of the funds, let's look at the most important drugs. Each department, let's see the drugs that you cannot go without. Then you make sure those ones are available. So we calculated, and we had about 40 drugs that we need to buy every week or every month. So those ones should never run out. And now we gradually increase the number as we get more resources. And now we are about maybe 60 drugs or 100 drugs that we are buying. So this is how we are doing it. So we said, number one is let's meet the basic needs of the staff. So the staff salary should be available. They should have proper restrooms. They should have proper things they need. Apart from that, we have to wait. Then after that, we have to meet the basic needs of the patients. When the patients come, they have to make sure their labs are available, basic things they need are all available in a hospital. And this is not only in Gambia, but across all other hospitals. We are making sure other satellite institutions that are under us, we are making sure that the labs are available, the staff they need are available, and basic things they need are. Now after that, when we meet all those basic needs of all patients, then we can now think of going into privileges for staff and patients. But as at now, we have to meet that. That's the philosophy we have sent, and people have bought into it. And that's why we're in a state where we have to make sure all the basic needs are already met before we can now think of privileges for the staff. So as of now, it's very tough with all staff and myself. Now, all privileges we have stopped so that the basic needs of patients. And that's why if you come to the hospital, usually infrastructure is changing. We don't believe that patients should be in very bad situation. So we make sure the fans are good, the ACs, there's nice renovation, and we are gradually improving.
I know that the donor community that donates to whether it's United Nations Global Fund, it could be NGOs, it could be any number of sources, including the Ministry of Health itself, may be developing in other African countries, maybe trying to develop these types of oxygen systems. And many times they think about the importance of scaling. So they want to get a low-cost system, usually a PSA system, and not pipe it. But this was done with a little bit different approach. The system itself was a little bit more money so that it would be more energy efficient, so that it would be more durable and be able to continuously work. And then more money was invested in piping the oxygen so that we wouldn't have to haul the cylinders around. But there's still a question that the international community has as to whether this is the correct approach for tertiary hospitals in Africa, or whether other tertiary hospitals in Africa that have similar needs for oxygen should just have scaled, the same type of scaled PSA system, just kind of drop there so that you could get more of them for less amount of money versus fewer systems and fewer hospitals, but they're piped, they're energy efficient and durable. There is what's your perspective on one approach versus the others? There's certainly pros and cons of each approach. What are your thoughts?
For me, because I've seen both and I've worked with both, I think I prefer a system where it's a little bit more expensive, but it's available and continuous. With this type of design where you have backups. But this is like perfect for Africa and for teaching hospitals because it ensures continuous availability. It might be a little bit more expensive, but I think it's a better way because what we don't want is to develop plans for management, for staff, and you have interruptions, then you go resort back to old systems, then you come back. So it doesn't allow continuity, it demoralizes the staff, and then you don't move forward because people just believe that this will not work. 2 years, you'll just find it there as a junk because people don't see it as something that is viable and they will put more investment in it. But if you have a system that is working continuously and with backups, so that if there's a problem, it continues to work whilst give you opportunity to fix the other side, I think that's going to work. And I think the other thing is that we should have a mechanism of getting the spare parts. We should have a mechanism of getting the spare parts easily. That should also be considered in whatever plan we are doing. I think, using Ghana, but we don't have the expertise in Gambia, but using companies that you did that are around Gambia, which are easily accessible, is going to help to maintain the plans so that they continue to run. In 10 years, when you come, you still find them here.
Okay, all right. If we're able to help you to get the PSA plant that's also at the hospital, but is more dedicated for providing cylinders for outside hospitals that don't have adequate oxygen, how do you see the Edward Francis Small Teaching Hospital's role in the national referral networks for scaling oxygen access around the Gambia? What would be your vision? We have the VSA plant providing the piped oxygen and the cylinders for the hospital itself, but you have the PSA plant that is run off of a diesel generator, but where you can actually probably calculate the amount of diesel fuel and resources needed to maintain the plant and generator and use that to calculate out how much you're going to charge for the cylinders. But I would like to hear what your vision is. If we can get both of those systems running, how do you see this whole overall oxygen situation in the Gambia?
I think it's going to be good for the country. Yeah, right now EFST is okay. We are fine because the VSA plant is working and we have oxygen supply in our sites. But, we are the apex hospital. So, and if other hospitals don't work, they just send here. And because of that, we have too many patients all the time and the demand is too high on us. But what was happening is the intermittent period that the PSA plan worked, what we did was we were selling it at less than half the price that it normally sells for private. So the other hospital, and we so the other hospitals were benefiting. They all queue to our place and get the oxygen. So the money that we were getting, we use it to buy fuel to run the place. We use it to maintain. So that was the essence. It was not for profit, but just to be able to maintain the machines and also to provide the fuel that was required and all that. And the other hospitals were very happy because they were getting it at less, because we were selling it at 5, and outside they are selling it between 2,500 to 3,000. And other government ambulances that benefit from oxygen and others, they used to come and fill for free because those ones are for charity. So the whole country was really benefiting. That's the system we want to continue. When you come in, we need to have a sustainable way. We don't even mind if a private farm runs it, so that the burden is out, not from us, and it will be more efficient. We don't mind, but we want it to continue to run and with money that is generated, be self-sustaining, and then and to provide oxygen to the public sector for a fraction of what we are currently buying for.
That's fantastic. How do you see, has this had any kind of an impact on the general morale of a hospital? I'm just curious. I mean, it seems like it would be a big effect in terms of the day-to-day operations and what people do, but I don't know whether this has any kind of impact on the hospital morale of the
I think that the austerity measures we brought in the hospital made the staff they were very, very upset. They were not happy. But with this type of investment, it has made them very happy now. And even the public, I go to the radio stations, and I remember, I usually expect a lot of, hostile interaction because, the hospital is not always very conducive when people come. And one of the hosts there, I was surprised and was very happy to tell me that when he came, how the oxygen was given, he had a patient here. And it gave me a lot of, the public seems to see it and they seem to appreciate, and it's benefiting them. So now I don't, in that situation, I did not receive those hostile interactions I used to have with the media. The host was very happy, and this is a well-known media in the country. And he was explaining his experience about the piping systems at the A&E and how it was. So it was so it seems that the public is even appreciating it.
That's great. Do you think that this type of infrastructure of having access to the essential oxygen that is needed will help to retain the obstetric and anesthesia talent? I mean, I understand that we actually graduated our first Gambian trained anesthesiologists last year, and we're hoping that maybe Gambia will be a location for actually scaling the number of anesthesiologists in West Africa. Gambia first, and then maybe even for other African countries. But I know that another problem is that when you train obstetricians, anesthesiologists, and surgeons there, I don't know, I think that sometimes they get frustrated and that helps to drive them to leave the country. Do you think that this will help them to stay there?
One thing is that from my experience, we get experts paying through the World Bank. We get experts to come to Gambia, and we pay them international salary because we have there's positive human resources in Gambia. So what happens is that when they come, first thing they want to know is, yes, they're getting the money, but if they are not able to do what they are trained to do, then they don't want to stay. They all want to go. And this is what happens to us as Gambians when they become fellows or consultants, specialists, and they have the knowledge now, but if they don't have the means to work. One of the things that an ICU internist or anesthesiologist need is a working critical care system. So they should be able to deliver critical care. They should be able to have oxygen blended. They should be able to have air suctioning, and they should be able to have the required medicine they need and the environment. And if this is not available, the monitors, the ICU system and all that, so they cannot practice their trade. So they tend to move to, even though you pay them money, and here we are not even paying. So the one thing that can motivate them is that if they are allowed the opportunity to be able to practice their trade. And that's oxygen system is one of them, but the ICU, the other things, we have to make sure they are available that's where they practice their trade, and that's what we are doing. So it's a big component of the whole system that they need to do their work. And it's very important because now they're able to use the machines. Before we had machines lying down there, but with this pipe system now, they're able to use those machines. Now, if it is only slender, they are not able to use it. So it's very important for their trade.
So we've just heard from Dr. Mustapha Bittye, soft-spoken. This man is very accomplished. He worked with both the Gambian health system, after a career as an OBGYN doctor, and then when the hospital needed his help, came back from the Ghana health system to the Edward Francis Small Teaching Hospital because of the extreme strategic importance of this medical facility to lead that facility, and has been a wonder to work with as we, from the Society of Critical Care Medicine and the Institute of Global Perioperative Care, have completed the development of an oxygen delivery system in this hospital. I hope that you will consider subscribing to our channel so we can bring more great content like this. And thank you for joining us today. Goodbye.